One and all. I'll be starting with the instruction course. So surgical management of pediatric cataract, video-based learning. So basic steps of pediatric cataract surgery for a novice pediatric surgeon. So congenital cataract has a worldwide prevalence of 4.24 per 10,000 people, with the largest prevalence in Asia. It is one of the most important treatable causes of child blindness. So what should be the timing of cataract surgery? Bilateral should be done around 6 to 8 weeks of age and unilateral around 4 to 6 weeks of age. We must remember that there are increased rates of postoperative glaucoma in the first 4 weeks of life. How should we make the incision? A superior clear corneal triplanar incision of 2.2 or 2.8 mm is preferred, as the wound is protected by the upper eyelid from trauma. Scleral incisions can be used when opting for rigid PMML lenses. And smaller, tighter fitting incisions help in the better maintenance and stability of the anterior chamber and minimize the times in and out of the eye. Two uniplanar 1 mm side port incisions, 180 degrees apart, give better maneuverability. How to address smaller pupils? Smaller pupils are less than 4 mm and they are associated with higher complications. They can be due to posterior synechiae secondary to uveitis, trauma, persistent fetal vasculature, pupillary fibrosis. We dilate preoperatively with tropicamide cyclopentolate, or we can use intracameral adrenaline, or now we have intracameral mix of adrenaline, lidocaine, and phenylephrine. So why anterior capsulorhexis is difficult in children? It is thinner and elastic, it is convex shaped, it tears easily and runs peripherally. AC is shallow in a smaller pediatric eye. IOP is lower due to less rigid sclera, and there is poor red reflex due to opacities. So how do we do the anterior capsulorhexis? We can do a curvilinear capsulotomy. We can use a vitrector to do the vitreorhexis, 2-incision push-pull technique. We can use a femtosecond laser, or precision pulse capsulotomy, or plasma blade capsulotomy. And what are the tips? We should pull the anterior capsule centrally, use a cohesive viscoelastic, and should take frequent bites of the anterior capsule. A high molecular weight cohesive viscoelastic should ideally be used, as it flattens the anterior capsule and keeps the anterior capsule taut. Multi-quadrant hydrodissection is very necessary, using a cannula on a 2 cc disposable syringe, and at least 3 quadrants of hydrodissection should be done. Coaxial or bimanual irrigation aspiration should be done. Start from the periphery and swipe clean. IOL implantation should be done only after filling the anterior chamber with high viscosity viscoelastic. Push the leading haptic and then the trailing haptic. A single piece hydrophobic acrylic IOL is preferred due to less PCO and pigmentary deposits. 3-piece can be used in cases of PC rupture. Monofocal IOLs are preferred in children. Multifocal can be done in ages above 5 years of age with bilateral cataracts. Lens should be ideally a hydrophobic acrylic material. Peripheral iridectomy should be done in cases of aphakia, uveitis, trauma with a vitrector, and if there is a bleed, then we can use intracameral air or epinephrine. Primary posterior capsulotomy and anterior vitrectomy should be done in all children less than 6 years of age, and just a posterior capsulotomy in less than 8 years of age. It can also be done in older children having nystagmus, or post-trauma, or having a posterior capsular plaque, and mentally retarded children. So suturing should be done in less than 2 years of age, as there is low scleral rigidity and increased elasticity, and there is a chance of wound gape. It can be done with 10-0 nylon or a vicryl suture. And finally, a preservative-free moxifloxacin should be given intracamerally. Subconjunctival dexamethasone can be injected, and we have also been using intracameral dexamethasone and triamcinolone intracamerally in children with good postoperative outcomes. Follow-up should be done regularly. Postoperatively, topical corticosteroids should be used up till 4 to 6 weeks, and topical antibiotics 4 times a day. Topical cycloplegics for up to 2 weeks, and a follow-up period with glasses and contact lenses and patching for visual rehabilitation. Now I'll come to some videos. Can you increase the music? This is a case of a pediatric cataract. We inject the trypan blue dye after making the uniplanar side port incisions, then wash it off. 0.06% trypan blue dye is used. Then we fill with viscoelastic, cohesive viscoelastic. Then we use the cystitome to start the capsulorhexis and complete it with a Utrata forceps. A multi-quadrant hydrodissection is done, and finally a bimanual irrigation aspiration is done. We should make sure to polish the capsule perfectly, because they are at an increased risk of PCO, these pediatric eyes. We are putting a 3-piece intraocular lens as the patient was not affording. Ideally, a single-piece hydrophobic acrylic lens is the best because it leads to least ovaling of the anterior capsule. And then we finally put sutures and air. This is another video in which we show we had put intracameral mydriatics. After staining the capsule, we put the intracameral mydriatics. That is a combination that is available nowadays. And you can see how beautifully the pupil dilated. The rest of the steps are same. We have to re-grasp the anterior capsule again and again because there is a tendency of going outside. Multi-quadrant hydrodissection as well as delineation is done. That's why we could see a small nucleus coming over in the anterior chamber. We can do a posterior capsulotomy initially, or we can do the posterior capsulotomy and anterior vitrectomy after we put the IOL. We should hydrate the side ports nicely. This is another video in which we used triamcinolone. You can see the beautiful lamellar cataract with riders. So congenital cataract is usually present at birth, though it may be missed. And developmental cataract is after 1 year of age, and it usually develops in the infantile or the adolescent nucleus. In this we have put a single piece hydrophobic acrylic IOL, which is the IOL of choice as it leads to less PCO, less pigmentary deposits, less Sine K. And finally we have put 1.2 mg per 0.03 ml of intracameral Canacot. This is another video in which we did rexes with a vitrector, as the capsule was very thick and attached to the lens matter. You can see the calcific plaques on the anterior capsule. We tried with a cystitome, but it was not possible. So we used a vitrector. The pupil was really small. So we need to use the vitrector at the cut IA mode. We make a nice opening of around 4.5 to 5 mm. The posterior capsular axis should be slightly smaller than the anterior capsular axis. But since we didn't have to put we have made a PI because the patient was left aphakic, as the corneal diameter was less than 10, or another indication is if the axial length is less than 17. So to summarize, congenital cataract is an important treatable cause of childhood blindness. It should be managed promptly to achieve good visual acuity. In the bag placement, along with primary posterior capsulotomy and anterior vitrectomy, is essential in the younger age group, and post-operative care and follow-up are inevitable to achieve a good outcome. Thank you.
Thank you, Dr. Parul, for your excellent presentation. I think you have covered almost all the basic steps.
Yes, sir. Yes, sir.
In the infant and children particularly.
Yes, sir.
When you apply sutures, you have some age group issue, or otherwise all patients?
Sir, less than 2 years, we prefer to apply sutures, either tenno nylon or vicryl, because there is they can be gaping of the side ports and the main port, and that can lead to ingress of fluid from outside and can further lead to end-offs also. So as the elasticity of the sclera is very less, so we should ideally put less than 2 years of age. But even in older children, if we feel that the wound is leaking, then we should put the suture. We should not hesitate to put the suture. So tenno nylon or tenno vicryl are good. And vicryl is absorbable, but it leads to slight amount of scarring and inflammation, more as compared to tenno nylon.
Any question from the?
Yeah, Those are very nice videos. Just wanted to know your preference for a single piece versus a three piece. Like, how do you decide when to do what?
So single piece IOL, hydrophobic acrylic IOL is always the best, but due to our children who are from a poor socioeconomic status, we tend to put more of three pieces, and three pieces are also more preferred in cases where we intend to do a posterior, where we intend to do a optic capture. So, or if there is a PCR, or in cases of posterior lenti globus, where the capsule is flappy and it has to be cut by the vitrector. So we tend to put the three-piece IOLs in those cases. But the fact is that the single-piece hydrophobic acrylic IOLs are the most biocompatible, and they lead to least ovaling of the anterior capsule rhexis.
Any relation to the visual axis obscuration between these two types of IOLs, three piece versus a single piece?
So hydrophobic acrylic as such, whether it is three-piece or single-piece, both have very less PCO as compared to PMMAs or silicone IOLs. But single-piece IOLs are definitely preferred, except where we have to do a optic capture.
And one last question, like, what are the conditions where you would not implant an IOL? Like, any situations where you would leave the patient aphakic?
Yes, sir. If the axial length is less than 17, some studies even suggest less than 18, or axial length, or when the corneal diameter is less than 10. So we try to avoid putting the IOL, and in fact we make a PI to prevent pupillary block glaucoma.
I think as far as three-piece versus single piece is concerned, initially we used to implant three-piece mostly. Now we are implanting more of the single-piece IOL.
Yes.
But as such, there is no change in the PCO rate when it is a square edge type of IOL, hydrophobic acrylic square edge type of IOL.
Yes, sir.
There are still many US surgeon and other, they still implant three-piece IOL. But as such, I think there is no change in the complication rates.
Yes, sir.
But I can say that a single-piece IOL should never be implanted into sulcus.
Sulcus. Yes.
Whereas I think we can implant three-piece IOL into sulcus
Sulcus,
in
yes.
case support is poor.
Poor. Yes, sir, definitely. It should never
Yeah.
be implanted because the haptics are broad. They will keep on rubbing against the iris. It can lead to UGH, uveitis glaucoma, hyphema syndrome, persistent iritis it can lead to. So three-piece are definitely preferred in cases of when we have to put the IOL in the sulcus. When the PCR is extremely big, we cannot put it in the bag. So we have to put it in the sulcus, and it is beneficial if we do a posterior optic capture. That will also lead to more stability of the IOL.
Any question from the audience? Any of you have any question? Although we will continue to deal with all the questions. Yeah, please.
So
Mic se le lo,
sutures,
mic.
sutures should be put in children where they suture management. So we did a study in which we did early versus late suture removal of 10 nylon sutures. So one group we removed the sutures at 2 weeks, and another group we removed the sutures at 6 weeks. So we realized that the rate of suture complications like loosening, attachment of debris, and those other complications, suture-related complications, are more in the 6-week group. And so we concluded that even removing sutures as early as 2 weeks is good. And we also compared the integrity of the incision on AIOS2025. So that was slightly better in the 6 weeks group, but considering the disadvantage of the suture-related complications, we concluded that it is better to remove sutures as early as 2 to 3 weeks in children. And for vicarial sutures, we don't need to remove it, but they tend to attract more debris, so we need to follow it up closely.
Yeah, please.
So posterior capsule rhexis can be done with a needle bent needle cystotome like we do an anterior capsule rhexis. It can be done after aspirating all the lens matter and with the cystotome. But if we need to do it with a vitrector, we can do it after placement of the IOL. So if we place the IOL and then do the vitrectomy, you have a better control over the capsule rhexis, and there is more chance of placement of a single piece IOL in the bag if we do it after putting the single piece IOL.
I think as far as this posterior rhexis is concerned, first we give a nick with the needle cystitome and then try to make posterior rhexis with the utrata forceps. Sometime we may be stuck up. So in that situation, it is better to use vitrectomy cutter. That gives more stable if you are going out. So in that situation, I think you can use vitrectomy cutter.
So you need to put it in the cut IA mode. The vitrectomy cutter should be in the cut
Cut
IA
IA mode. IA cut is for aspiration. Cut IA means that you are cutting but not aspirating much.